pediatric airway, when we intubate, you get through the cords are wide open for kids. That's not the smallest point. What the smallest point is at that cricoid ring. So we put tubes in, or a tracheostomy tube in, based upon what we think the cricoid cartilage ring size is. So you get a ventilator breath, and then the cricoid ring actually seals it against the tube, which prevents exhalation. Now, the problem with that in pediatrics is that you don't have a cuff to deflate, you don't have any airway room around the outside of the tracheostomy tube. How do you get vocalization using a Passy-Muir valve? You need to downsize. And that's pretty common in kids, is downsizing the tracheostomy tube. The pressure in that being that one healthcare professional may want to promote ventilation and may be really concerned about ventilation. You're balancing that against the need for vocalization and growth and development. And if you are very in tune as a healthcare team, you'll balance those things out correctly. Our physician would say to us, yes, I think that we could probably make these manipulations in the ventilator in order to promote this vocalization. And I think that that's important, an important balance. And so that's the give and take in that. Adapters are basically the same as well. The same adapters fit. And applying humidity and oxygen is the same way. What we use a lot in pediatrics is just the trach collar. And it's just a little thing that sits over the tracheostomy tube, and say they didn't have a Passy-Muir valve, they would have the collar on and they'd be breathing in and out of their tracheostomy tube any oxygen and humidity they'd need. So you put a Passy-Muir valve on, you take up the trach collar, you put the Passy-Muir valve, and you put the trach collar back on. How do they get their oxygen? Say that again? Same way. They're getting it through their Passy-Muir valve because they're inhaling around through all their oxygen in through their trach collar. A lot of people are like, well, how are they going to get their oxygen? Same exact way, and they get their humidity the same way. So basically, the equipment's the same. It's really nice. Some other things you want to then begin to work through and think about and consider and develop plans for are kind of the caregiver and child bonding implications that you may be able to work with. Because of the tracheostomy tube, sometimes, not in all cases, the caregiver has done a lot of medical care, and perhaps they've had a lot of nursing care in the home, and that can really put little bits of boundaries between that parent and that child. A lot of times that won't happen, but sometimes it does. And begin to consider those pieces. Begin to work on speech and language development. The beautiful thing about this is that once you use a Passy-Muir valve and you don't have any other big equipment in the way, or you have to use, luckily in pediatrics, electrolarynxes don't work very well. I mean, you put that up, you have the child hold it, no, it's not going to work. So you very much are limited in what you can do in pediatrics, this being probably the only thing that actually is easy to use and works very well. Speech and language development then can continue in the exact way you would work with a kid without a tracheostomy tube. It's wonderful. I have one family that I work with that, it's funny, a child has a tracheostomy tube, and even though that life is attempting to be very, very normal, and you really normalize everything you possibly can, when you work with a child with a tracheostomy tube, what do you look at? You look at their trach a lot. And so that something's got to be, getting in the way of some of that normal growth and development kinds of things. Just because I think you're a little more careful with a trach child, you wouldn't take a trach child and just kind of toss them in the air and throw them around like you would a healthy child, so that they don't get that vestibular stem in the same way also. So that growth and development in very small ways can be affected just because of the trach being there. So speech and language development now can continue in the exact same way you've always been able to do it without a trach tube. Then you begin to work on the swallowing and the feeding issues. Roxanne's going to talk about that in general, but that a lot of times in pediatrics there's some fear that perhaps it causes increased work of breathing. And like I think Sherry was talking about, and the case group this morning was talking about, was that it's a trade-off. You'd have to balance whether or not that is of value. And many times in kids, the increased work of breathing is not that significant with the Passy-Muir valve on to nil. And so that you put it on, and a lot of times they swallow and they feed better, but there's still a little bit of an underlying fear that you're blocking off the tracheostomy tube. You're putting this thing on there, and it makes it harder to swallow when that's actually not the case. But it's a real mental thing that kind of people go through. And socialization. These are some really cool boys that are much older now. They also have congenital central hypoventilation syndrome, but can you imagine like the socialization differences with no voice versus just a voice? I can just imagine them playing and rough and tumbling it. I think that kind of speaks for itself. So socialization in that sense, in the family setting, as well as socialization in the school setting. A tracheostomy tube can frequently be a little intimidating, not only to teachers, but sometimes to speech pathologists that may not be real familiar with tracheostomy tubes. Just they don't get the quantities of them. You know, they may see one tracheostomy tube in their entire school, or some of the trach children go to maybe one centralized school. It kind of depends upon your system. And so that a Passy-Muir valve can actually normalize some of that socialization between the teacher and between the school nurse, and also between the other students that are in the classroom. Just normalizes things and makes things a little better. Also, the secretions aren't coming out. With a Passy-Muir valve, then the child has to cough up secretions in the normal way and just swallow them like all other kids do. So it's really valuable even for normalizing some of that. And what I've got now is a videotape of a young man by the name of Leo. Leo has Wernicke-Hoffman muscular dystrophy, and this is sort of not the classic speech and language kind of work that you would probably do. He is probably got a lot of oral floppiness. He's not probably going to speak in the classic terms of speaking, but I want you to see how valuable this could be to just his mom and to himself. I think it's really valuable.
This is Leo, and Leo is a little bit over 1 year old, and he has Wernicke-Hoffman disease, which is a type of muscular dystrophy. And Leo likes to jabber and coo and talk a little bit, and he's been practicing with his Passy-Muir speaking valve for the last couple weeks. What I'm going to do is put it in line, and you can hear right now that he's pretty quiet. He makes a few little sounds. Are you making sounds? Yeah? Okay, so what I'm going to do is I'm going to put this in your circuit. You ready? Okay. Now can you talk for me? Are you talking? You making some noises? Are you gonna sing? Huh? Goodness! What? Do you like talking? Do you? What? And you can see that right now he's feeling the secretions in the back of his throat. And his level of respiratory distress isn't bad. I mean, he's just about the same as his normal respiratory rate. And he's enjoying himself.
So that may not be some of the classical ways you would think of speech and language and some of the work you do, but it was incredibly valuable. You could tell he was just so proud of himself, just so proud of himself, and his mother loved it when she could come in and she could do that. And I think it just made his world a little bit different. So he was making me laugh in the background, though, because it was the first time that I had heard him so loud. So he was cracking me up in the background. So the other pieces of placement with the Passy-Muir valve, as you're placing the valve, now I'm going to do an actual placement, and we'll go through some of the things that you want to consider as you're doing a placement in pediatrics. Obtain your baseline measurements. Get your saturation just as you would. In kids, sometimes we don't allow the saturation to drift down as in maybe 92, maybe a cutoff, but really consider who what your facility's kind of norms are for kids. It varies in different places throughout the country, but it may be that you want to consider that keeping the saturation above 92. It really varies though. But know your heart rate and your respiratory rate norms, that child's baseline norms, and how high that heart rate really needs to go. In adults, you sort of know that if it goes to 100, that's kind of a lot for an adult. If you have a child that has a heart rate normally of 150, is 160 a lot, or is 180 a lot? Is 200 a lot? What is your a lot number that then considers that it's not working? You want to know those pieces of information. You want to show the child the valve before placement. Even for a 3-year-old to hold the valve and at least know what, that they can touch it and they can feel it and that it's going to be part of them, really helps them adapt to it. You want to educate the child and family about the Passy-Muir valve, and we've talked a lot about education today. Education varies from different age groups, every various age group child, but the parents can be very instrumental. I had one little girl that I worked with who just really was very resistant to using the valve. And because mom was so educated in using it and very pro just vocalization, getting off to school, doing normal things, she really worked hard and she insisted that she was going to use it, and she used it full time. So, and it was because of mom that she really was able to do that. You want to position the child very comfortably. This is Matthew. Matthew's position of comfort was up in his chair, being able to do things with his parents and seeing the world upright. Leo, the little videotape that I showed you, he hated his wheelchair. It was very uncomfortable to him. And so when we put him up in his wheelchair, he cried a lot. And so that for him, that wasn't his position of comfort. His position of comfort was on his mat that had the head of the bed, the head elevated. And so that was great for him. So position of comfort can be important. You want to suction the child as needed. In pediatrics, I think maybe I get a little bit used to suctioning large quantities of secretions, but it doesn't seem as if we have some of the same issues because secretion quantities are just smaller. And so that, but sometimes we just suction more frequently because when they do occur, respiratory distress is common, and they need to be suctioned right away. So suctioning, every half hour is not particularly unusual in kids. You want to deflate the tracheostomy cuff if it is present, which most of the time it is not. And place then the Passy-Muir valve on the tracheostomy tube hub. You monitor and observe the child closely to determine tolerance of the Passy-Muir valve, just as with the adult. And just remove the valve immediately if signs of respiratory distress are observed. They may need to start wearing with short wearing times. And that can vary, like we talked about, anywhere from, if I get 15 seconds, 20 seconds in my first try, I'm a happy camper. 15 minutes is wonderful. And I may just go ahead at 15 minutes the first time, even though the child's not in distress, and just take it off. So it really varies. You increase the wearing times then, as tolerated. Begin to encourage vocalization and or speech, just through your normal practice. And now what I've got to sort of demonstrate just kind of the encouragement process in pediatrics is a young boy by the name of John. And I have a little description on there. He had bronchopulmonary dysplasia and tracheal stenosis. And so he could wear it for short periods of time, not all the time. But I'll let you kind of look at the encouragement that was necessary for this young man. Gorgeous boy.
This is John, and John has a tracheostomy tube, right? Yeah. And you're still on oxygen. When he was born premature, and he was on the ventilator for quite a while, and he's doing very, very well. So what we're going to do is we're going to put the Passy-Muir valve on you. And can you talk for us then? Would you be able to talk for us? This is kind of funny, isn't it? Okay, let's ask Mommy to do that. Where's Mommy at? Mommy's trying to avoid the camera.
You gonna talk to me? Please. Please talk. Let me hear you say, Mommy. Talk. Say, Bill. Talk. Say, Mommy. Come on. Talk. Come on. Please.
Would you like to play with the lawnmower for a while? No? You want me to play with the lawnmower?
Come on. We're gonna
Put it on.
clap. We're gonna clap. Come on.
Put it on.
Come on. Yay! Say five. Say five.
What up, dude? John. John. How you doing? You want my keys? Want my keys? You want my
You want
keys?
kids?
Huh? All right, here you go. You can. You gonna drive?
Where's his car?
Where your car?
I'll go get it.
You
gonna drive your car?
You gonna
Down,
drive your
down.
car? What do you say? Thank you. What?
Thank you.
Okay,
Want
you're
your car,
welcome.
Dad? Want your car? Here. Here. Oh, come on. Let's get in. Come on. Let's go. Get in. Let's go. Get in the car. Now, put your keys in. Put your keys in.
Close the door.
Okay, you got the keys.
Close the door.
Close the door. Uh-oh.
Tell him see you
Say
later.
five. Say five. Say
Hey,
five.
John.
Come on. Let's say. Say 5, 10, 5, 10. One. Say 1. Come on. 2, 3, 4, 5, 6, 7, 8, 9, 10. Yay!
Hey, John, I'll see you later.
Bye.
Bye-bye.
Okay.
You gonna drive off? Where you
drive.
going?
You gonna
Where you
drive?
going?
Where you going?
See Batman?
You want Batman? Oh, you want to see Batman?
See Batman.
Batman. Say Batman. Yeah.
Don't you wish you had a relative like that with you, maybe, whenever you were working with kids? You can just see, I mean, this was a very good family to work with, and very loving, and very good-looking family, too, I mean, so that he was really fun to work with. Now the lovely motivation and distraction ideas, you can see that he would have helped in ways that we may not have, we may have failed because we're the adult, and sometimes kids can really get to other kids. But you start working on your motivation and your distraction ideas, Barney videotapes, play out in their very favorite place in the backyard. Things like that kind of help really motivate and distract the child. Then you want to begin to implement wearing the Passy-Muir valve during feeding times as appropriate. Kind of a staged approach. First you try it during your easy times, then you try it during your little more stressful times. And this young girl is eating her birthday cake as she's wearing her Passy-Muir valve. She has quite a big plate of birthday cake too. And you begin to build tolerance of wearing the Passy-Muir valve then in stressful situations. You want to develop the ability then to have the child wear it during crying and whining and kind of resistive activities, because that's when they need to be able to verbalize and say, I don't like that. And so just because you may not like them to be able to make kind of those louder sounds during those behaviors, that's when they actually need it the most, just so they can verbalize those things back to you. One of my biggest philosophies in children is that children really sort of are very easy to work with and don't have all those fears and kind of anxieties, and so that kids really do what kids want to do, and so that I don't know, it becomes very easy to know that the physiologic reasons then are most of the time why things aren't working. It's not that you can go through and say, well, I think that that child's anxious, or, you know, gosh, they really just don't want to wear it. I think most of the time they do, and what we forget to do is click off all those physiologic things that could actually be happening. Is the trach size too large? Is there granulation tissue? They really very much work on the physiologic mechanisms that as compared to more of a fear and anxiety, and I love that. Contraindications for use of the Passy-Muir valve include severe stenosis, excessive granulation tissue growth, severe tracheomalacia, tracheal edema, and severe medical instability. Thick and copious secretions, although it really doesn't happen that often in pediatrics, and bilateral vocal cord paralysis in the adducted position. Severely reduced lung compliance is another contraindication, and also the use of the foam-filled cuff tracheostomy tube, particularly the Bavona tracheostomy foam cuffed tube.
Did anyone have any questions for Angela?
The question was, could I give sort of some sizes that are norms for different age groups? And it's really interesting. There is not any documentation as to what particular weight child uses a particular size tube. And the reason is because the use of the tracheostomy tube is so different. A size would be different for a child that was being mechanically ventilated versus not mechanically ventilated, because you can really downsize those and put in a smaller tube. You know, if I were to guess, I could probably give you kind of some average guesses, but if you had a, 5-year-old with a size 4 tracheostomy tube, that seems about average. A 1-year-old maybe with a size 1. You can't always say that a 1 equals a 1-year-old, a 2 equals a 2-year-old. It doesn't really work like that. It really based upon the disease process, but that's kind of an average.
For a non-ventilated child at the age of 4.
She's saying if there was a non-ventilated patient at the age of 4, it really depends upon if they're getting close to being decannulated, but a size 3 definitely would be kind of an average size. And that's just based upon experience. It could be that it's a 4, it could be that they're decannulating, getting ready to decannulate. When kids are decannulated, there's a couple different ways that different institutions decannulate children. One is that, say they've got a size 4 tracheostomy tube, you decannulate them in a size 4. You just take them back to the operating room, or you take them to a controlled environment, decannulate them if they're ready, and watch them, and then discharge them. Other institutions will downsize, and they downsize from the 4, a couple weeks later to the 3, to the 2, to the 1, to the 0, even then putting the obturator in to create even more of a plug. I tend to see that the Passy-Muir valve helps with that transition even better, because at least it allows them to do one thing at a time and practice that. That's a good question. I wish I had the answer. Okay, that was good enough, she said. Yeah.
How soon are you placing the Passy-Muir sleeping cups on neonates?
I've heard of one child that was about 2 weeks of age that they actually started to use the Passy-Muir valve on. It was a neonate, and it was about 2 weeks. Sherry, do you have some?
I know over at Texas Children's, they're using them as early as just a few days old.
Okay.
Are these premature or full term?
Premature, full term?
The majority are probably craniofacial.
Right.
So they're full term.
Okay.
What Sherry was saying was that she was saying that she had some experience in Texas where they're using the valve at a couple days of age, but that may not be so much the premature population as perhaps the Pierre-Robin children, kids with craniofacial disorders that require a trach for a little bit different reason. Remember that you have to wait for swelling and airway edema to go down, and that really varies upon kids too. There was another question.
Actually, 2 questions. One, when you use it in line with a ventilator and
Mhm.
the child is on PEEP,
Mm-hmm.
do you change your PEEP at all?
The question was, is if you've got a child that's on the ventilator and has PEEP, do you change your PEEP at all? It's just like the adult population where you want to take your PEEP down to 0 because you're going to develop some auto PEEP. That can be a problem. And you know, in an adult, if you change your PEEP from 4 to 8, it's not so much of a problem. But in kids, if you went from 4 to 8, that could be a really significant problem. It's something to really remember. We were in the last conference in Nashville, and it was really interesting. We were showing one young man getting his valve placed in front of us, and that we had just forgotten to take his PEEP off. And I said, you know, I don't feel like he's getting good exhalation. And I couldn't figure out why I was saying that, and we had just forgotten to take his PEEP off for a second, and once we did, then we heard really good exhalation. Good question.
The other thing that I found is that at least our policy of our hospital is
Mm-hmm.
when you use the Passy-Muir valves, they should be used only when the child is observed and not during sleeping hours.
That's a good point.
Your policy.
What institution do you work at?
Actually, I work at SUNY Health Science Center in
Great.
Crossville.
Great. She works at, and I guess it's pronounced SUNY? Okay. She works there, and one of her policies is, and their institution policy is that the child must have the Passy-Muir valve on while observed and also not during sleep. Some children tolerate, you know, you walking in and out of the room or the not observed thing a little bit better. There are some children that just because of their oral floppiness, if they go a little bit to the side or a little bit this way, they can obstruct. And so those are the kids particularly you want to have on your policy as being observed. And the no sleep, you know, not having the valve on when the child's asleep, is just like based upon the adult population. The recommendation by the Passy-Muir company is that the valve is not worn during sleep. The question was, do we bronch all children before using the Passy-Muir valve? Definitely no. I get so much information by using a Passy-Muir valve, even in the home care setting, in the school setting, in the acute care setting, that, you know, if for some reason they have an obstruction and I can tell it by using the Passy-Muir valve, then you'd probably want to consider it as one piece, you know, that you'd probably want to do. But many a kid we use, just put it directly, try it, and see how it works.
When a child gets old enough to take it off themselves and they continually take it off, what have you done?
This is a good question. Is that okay?
Yeah.
Okay. The question, or actually the comment was, and this is a really good point in pediatrics, is the child was getting old enough and they were taking it off all the time. What do you do? First off, since kids are so, I think really just they really are very physiologically based. Think about the things that are making the child take it off. And I think through, first off, I give the child credit and I think, what's going on physiologically? Is it something like that they aren't feeling like they're getting all their breath? Or are they not exhaling correctly? How is it uncomfortable? And then, after excluding everything I possibly could, then I go on probably to the behavioral things. And that can be a problem. And then it comes down to the parents insisting. It's just like any behavioral other issue. You're going to have to sit down at the table and you're going to have to eat all your meal, just the same way as I want you to leave that on. And using timeouts and pieces like that. But that is an issue.
I wanted to respond to yours as well as in using it for an assessment, that the Passy-Muir valves, now that we've become single packaged, they do allow you to use them for assessment and you don't have 2 per package. They're also reimbursable in Medicaid and Medicare. In California, we have California Children's Services, and they are reimbursable through that. So you can look into your state children's services and see if they're reimbursable for that as well.
It just is so much cheaper to me than using the communication boards. I've always had trouble in trying to plan for a child's communication board, and then by the time you finally get all the paperwork done and you get it implemented, the child's way past that developmentally. And so that, and then usually the reimbursement, we had a Medicaid audits that would come in and that would look and see whether or not we were actually using that piece of equipment, and would then judge or base all the further decisions then upon whether or not we use that first piece of equipment effectively, which was very hard. So, are there any other questions? You guys have been.
You said in the past that it does help out in feeding, senses. How about taste specifically? Children
Do you want to?
starting on oral feeds or baby foods, things like that, taste-wise.
Taste-wise, I mean, taste is so much an olfactory thing, actually. And so just what the adult population, yes, it improves. Now, the question and the problem is that feeding in trach children is a problem in general. They've been suctioned. They usually come with oral defensiveness, oral aversiveness. That can be anything from, they started out feeding when they were 2 months of age and they don't want to eat and they're very resistive, to vomiting behaviors, gagging behaviors, to refusal. And so that it's very difficult in the pediatric population to distinguish some of those things going on. All I can tell you in feeding is that the earlier the better. Make it pleasant and don't focus on quantity. We'll focus on quality. But oh, it's a problem. I've known 5-year-old kids. Back in the olden days, we did not feed kids. We would think, oh, they're going to be fine. We'll just let them, everybody wants to eat, especially me. And so that they'd wait and they'd allow the kids to finally just decide on their own, and they didn't. They I had one girl that she'd get lotion on her hands and she would vomit just because of the oral, tactile stuff going on there.
Do you think children would eat that with the Passy-Muir?
I tell you, what happens is that they get discharged so quickly, and a lot of my experience is more acute care, some home care, and by the time they get to that point, they're usually either decannulated or they're feeding very well. And so it's hard to distinguish. If I were to say anything, I would say yes, just like with the adult population. The sensation's better, the secretion management is better, and Roxanne's going to talk to you about that a little bit this afternoon too. So. Yes.
Is the valve contraindicated for the baby with oral aversiveness?
The question is the valve contraindicated in a baby with oral aversiveness? A lot of oral negative behaviors. No, absolutely not. Actually, if in time and with the right kind of therapy program and oral stuff, can actually help, hopefully. Okay, great. You've been a good group. Thank you.
All right. All right, we're going to go ahead and do the dysphagia section now. We at Passy-Muir are very grateful to have our guest speakers today. And our guest speaker who will be presenting the dysphagia issues is Roxanne Diaz-Gross. Roxanne is a speech-language pathologist, and she has extensive clinical experience and is currently pursuing her doctorate at the University of Pittsburgh with an emphasis in dysphagia. She has lectured nationally, co-authored several research articles on dysphagia in tracheostomies and ventilator-dependent patients. She has authored a swallowing rehabilitation chapter in Cancer of the Head and Neck, 3rd edition, Saunders, 1995. Some of her recent independent research has directly involved the Passy-Muir speaking valves, and some of the results she will be presenting to you today. Roxanne?
Hi, everybody. I'm the last speaker of the day, and I want to thank Passy-Muir for allowing me to lecture. Anyway, who gets dysphagia? Certainly our neurological, neuromuscular patients. These are the same folks that have cognitive language disturbances, motor speech disturbances.